Good afternoon, everyone. Myself, Dr. Sri Durga. I'm from Tirupati branch consultant. So today, I'll be telling you about an important topic, that is IVF protocols. So before we discuss about actual protocols, I just wanted to add a note on the history, how far we have come in this field. So initially, when the first IVF baby, Louis Brown, was born, they have done more than 300 egg pickups before the first successful IVF. So see where we have come now. We have come a long way in the protocols, long way in the development of drugs also. And they used to carry eggs in between labs. They used to carry in a container strapped to the body. So that's how they used to carry because of the lack of culture conditions. But now we have so many advances even in the lab. We have the most advanced lab facilities now. So whenever we stimulate a patient for IVF, what should be our goals? So what the patient wants obviously will be a healthy baby. So what our goal should be is a singleton live birth at term should be our goal, and to maximize the beneficial effects and to minimize the complications and risks. So we have to see the cycle cancellation rates should be minimal, and multiple pregnancy rates should be minimal, and there should not be any hyperstimulation cases. So we have to minimize the risk of hyperstimulation. So these should be our goals whenever we have to stimulate an IVF cycle. So in this class, I'll be telling you what are the different protocols we use for stimulating patients for IVF. And there will be different type of responders. Some will respond in an exaggerated way, hyper responders. There will be poor responders. So we'll discuss about which protocol to use for whom, and how to decide upon the dosing, and what are the drugs we use, the agonist and antagonist protocols, and a note on poor responders, and a few points about random stat and dual stimulation also. What is the main difference when we stimulate a case for ovulation induction and IUI and IVF? Can anyone let me know how many follicles we aim for when we stimulate in an ovulation induction cycle?
It's just a single follicle.
Yeah.
Or one or
yeah.
two. Yeah.
Yeah. So in an ovulation induction cycle, we always aim for a monofollicular development, right? So whenever we try to stimulate for IUI, maybe we aim for 2 or 3 follicles to improve the success rates. Because in an IUI cycle, we'll be using gonadotropins in addition to oral ovulations. So we aim for 2 or 3 follicles. In IVF, what we do is we'll aim for multiple follicles. Whatever follicles which are present in that cycle, in that particular cycle, we'll try to stimulate all the follicles, and we'll try to get as many eggs as possible so that it will improve success rates. So that is the main difference. And so you all must be aware of the basic steps of IVF. What we do is first we have to stimulate the ovaries with gonadotropins. So once the follicle reach an adequate size where we get mature follicles, then we give a trigger injection, and then we time the egg retrieval and we do the ovum pickup. And then after the ovum pickup, we see the oocytes, and in the lab, we see whether we have got mature oocytes or immature oocytes, and only the mature M2 oocytes will fertilize with the sperm. So fertilizing the egg with the sperm and forming the embryos. And later on, we can do either a fresh transfer or a frozen embryo transfer. And after the transfer, 2 weeks after the transfer, we see the beta HCG test. So the basic steps of IVF are, we have to do stimulation, ovum pickup, and the embryo transfer. So you should have an idea of the number of days of stimulation, how many days usually it will take. There is no minimum number, but usually it will take around 8 to 12 days according to different cases, and based on the number of follicles, usually it will take around 8 to 12 days. The types of protocol we'll discuss in the next slides. And how many hours of trigger we do egg pickup and all, I'll tell in the next slide. So whenever we do a stimulation, different patient respond differently. So what we call as a high ovarian response and what we call as a low ovarian response. So whenever we do a stimulation, when we see more than 18 follicles, more than 11 in size on the day of trigger, then we call it as hyper response. And usually when we get less than 3 follicles on the day of trigger, then we call it as a low response. There has been debate about this topic, like we should be getting more number of eggs or more quality of eggs. So whenever we stimulate, we should keep in mind that even though we get worst cases, we get multiple eggs, like 20 to 30 eggs we'll get, but the quality may not be that good. So our aim should be getting optimum number of oocytes so that we get good quality embryos, not more, not less. So we need eggs, but not all the eggs. So it is saying that the more the better, but less is more in terms of quality. So we need eggs, but not all the eggs. Normally 8 to 17 oocytes if we get, we will be able to achieve good quality embryos and good pregnancy rates. Before we know about stimulation, we should be very thorough with the physiology of folliculogenesis and how the oocytes get recruited in the cycle, and very thorough knowledge about the proliferative phase, then secretory phase, how the follicles get recruited. So you all must be having an idea, just a brief review of the physiology. So on day 2, whenever we see a scan, we see follicles. So those are the antral follicles which we are seeing on a day 2 scan. So they have come from the stage of primordial follicles till the stage of antral follicles. So these antral follicles will be 2 to 5 millimeter in size. These are responsive to FSH. So whenever FSH comes into play, these antral follicles will grow in size, and usually what happens after day 5, one follicle will become dominant, and that follicle will grow, and rest of the follicles will undergo atresia. So what happens in a normal cycle? On day 2, the follicles get recruited, and the FSH just starts rising briefly. So from day 2 to day 5, it is the FSH window, and after day 5, one of the follicles which has the maximum number of FSH receptors will become dominant. So all the other follicles will undergo atresia, and that the dominant follicle will undergo ovulation. So what we do in IVF is we try to prolong the FSH window. How we do that? We give exogenous gonadotropins in the form of FSH and LH. We try to give FSH exogenously, and so we try to prolong the FSH window. So all the antral follicles gets exposed to this higher amount of FSH for a longer period, so that all the follicles get recruited. So more and more follicles will cross this FSH threshold, leading to selection of multiple dominant follicle and multifollicular development. So this is a very natural cycle. So on day 2, we see that 4 to 5 these are follicles. So why to rule out how many any cysts are there or any dominant follicle has developed, especially in poor reserve cases. Whenever we see scan on day 2, already one follicle will get selected. It will be more than 10 So we have to see if there is any dominant follicle has already recruited or not. So we have to rule that out in a day 2 scan. And So on day 2, how the hormonal milieu will be in the blood. So the estrogen, when we see on it on day 2, it will be less than 50 picograms per ml, and the progesterone also should be less than 1 nanogram per ml, which is baseline. And FSH and LH between 2 to 8 international units it will be. Yeah, this is the concept of FSH window. In a spontaneous cycles, the FSH will be steady and the threshold will be low. So what we try to do is we give HMG and FSH exogenously, so that we'll try to prolong this FSH window and then stimulate multiple follicles. So how many follicles will start will grow at the start of the cycle? So whatever follicles which are there, we'll try to recruit all of them. In a natural cycle, only one dominant follicle will grow, but in a stimulated cycle, we'll try to recruit multiple follicles, and so that we get multiple eggs. Yeah, the same thing. So our aim should be to recruit multiple follicles, as well as whenever the multiple follicles start growing, all of them will be secreting estradiol. So normally on day 2, the baseline estrogen will be less than 50 picograms per ml. But whenever a follicle starts growing, each follicle will secrete at the time of ovulation, it will be secreting around 200 picograms per ml of estrogen. So whenever multiple follicles are growing, the estradiol levels will be supraphysiological. So whenever the E2 will be greater than 200 picograms per ml, if it is sustained for 50 hours, then it will exit a positive feedback on LH, so that LH surge happens. So this is why LH happens with high estrogen levels. Our task in IVF should be to control this premature LH surge. So two things: we have to recruit multiple follicles. At the same time, we have to prevent this premature LH surge from occurring. So the same concept, whenever there is a single dominant follicle, monofolliculogenesis. In IVF, we do multiple follicles, recruit multiple follicles, and multifolliculogenesis. So the important concepts here are, main thing is the FSH threshold. We have to surpass the FSH threshold to initiate the secondary recruitment. And the FSH window means the time frame for which this FSH needs to be maintained for follicular recruitment is this FSH window, which we meet by giving exogenous gonadotropins in high dose. With increasing dose of gonadotropins, we increase the FSH threshold, and we prevent the LH surge by using different drugs like agonist, antagonist, and we can even use progestogens. So what we are doing is a controlled ovarian stimulation. So in a controlled ovarian stimulation, our aim should be to recruit a uniform cohort of follicles. So one becoming 20 mm, one is still 13 mm. So we don't want a cohort like this. We want a uniform cohort of follicles, so that we'll get 10 to 15 good quality oocytes. And also we should get adequate embryos for freezing or either doing for a fresh transfer. And also at the same time, we have to avoid ovarian hyperstimulation also. So you all must be aware of the indications of IVF. So whenever there is any tubal factor, complete tubal ligation or any bilateral severe salpings, then we can go for IVF. And also prolonged duration of infertility with the factors also we can do IVF. And in case of severe male factor with less than 1 million count, first treatment of choice is IVF with ICSI. And in cases of severe endometriosis also, we advise IVF. So what we are doing now, either conventional IVF or ICSI. So conventional IVF means previously what we used to do is in a petri dish we keep oocytes and we put 50,000 of motile sperms so that it will fertilize on its own. But nowadays we are doing universal ICSI for all. That is directly in one egg we are injecting one sperm. So ideally, we should be doing ICSI for severe male factor cases, but we are routinely doing ICSI for all to improve the fertilization rates and the blastulation rate. Yeah, whenever we are doing IVF, we can do either a modified natural cycle, mild or conventional IVF. So previously, before the start of gonadotropins, what they have is natural cycle IVF only. So naturally, whatever follicle which gets selected in that cycle, so they used to pick up that oocyte and do this IVF. But the disadvantages with the natural cycle IVF is there is high risk of cancellation because we cannot control LH surge or we cannot time with the trigger. So natural cycle we are not doing right now. And the modified natural cycle IVF, we aim for one oocyte only. Same as natural cycle, whatever follicle which develops in that cycle naturally, but we time with HCG trigger in the modified natural cycle. Again, this is also very less number of oocytes, so we are not doing natural and modified natural cycle IVFs now. Next thing is mild IVF. In mild IVF, what we do is we, along with oral ovulations, we use low dose gonadotropins also, and we use antagonist protocol from day 6 to day 7. So in mild IVF, we aim for 2 to 6. Yeah. Yeah. In conventional IVF, we aim for more than 8 oocytes. So either in conventional IVF, we can do either an agonist protocol or antagonist protocol with FSH as well as HMG. So the problem with natural cycle IVF is we have difficulties in timing the oocyte retrieval, and it requires very frequent monitoring because we don't know when the follicle will rupture, and we cannot recruit more number of oocytes in natural cycle IVF, and there are high cancellation rates and reduce the chances of successful oocyte retrieval and very low pregnancy rates. So our aim should be to recruit more follicles by using oral ovulations and gonadotropins and to control the premature LH surge with the GnRH analogs. So the protocol of Louis Brown was the result of natural cycle IVF, which was done by Edwards and Steptoe in 1978. So after that, so many advances came. So these are the different protocols which we use for stimulating ovaries. The main protocols are the antagonist protocol and the agonist protocols, where we use GnRH antagonist and GnRH agonist. In agonist, again, we have long protocol and short protocol and ultra short protocols. And there are few special protocols which we use in some cases, like dual stimulation protocol. In poor reserve cases, we do these special protocols. So to understand stimulation, the basic concept is in an agonist protocol, we start from day 21 of the previous cycle. We start with the GnRH agonist, and on day 2 or day 3, we start with gonadotropins. So after doing the baseline scan on day 2 or day 3, we'll start with the gonadotropins, either FSH or HMG, or we can give combined FSH and HMG, and we monitor the growth of the follicles. Class. Just a minute. Stock, okay, skip check. From day 2 or day 3 of cycle, we start monitoring. From day 4, day 5, we see the growth of the follicles. So according to the protocol, we either give antagonist from day 5, day 6, and agonist protocol, we continuously administer agonist toward the stimulation. And whenever we get 2 or 3 mature follicles, we plan for trigger. So what are the gonadotropin preparations which are available? We have HMG, which contains both FSH and LH in equal proportion. And we have urinary FSH. This was used previously, but it has high non-gonadotropic protein content, so it is very impure with less efficacy. So urinary FSH we are not using right now. And pure FSH, FSH with non-gonadotropin protein content less than 5%. So we can use highly purified FSH. And now we are using recombinant FSH because it has high purity and it does not have LH activity also. And recombinant LH is also available. But recombinant LH we don't use routinely in clinical practice because it is very costly and not easily available. This is cortifolitropin alpha. It is a long-acting FSH subcutaneous preparation. This also we use rarely. The main drug we use is recombinant FSH and HMG. Yeah. So recombinant FSH is more potent. So more than urinary preparations, we prefer using recombinant FSH. The Cochrane show no clear difference in the live birth rates between recombinant and urinary, but we use recombinant FSH. The GnRH analogs, the types of GnRH analogs are agonist and antagonist. Agonist acts by downregulating the pituitary receptors. So whenever we give a GnRH agonist, initially it will cause a flare effect. It will stimulate the pituitary, release FSH and LH. And after the initial flare effect, it causes a desensitization of the pituitary and then cause pituitary suppression. On the other hand, antagonist, it does not downregulate, but it directly competitively binds to the pituitary receptors and causes inhibition. Yeah, so the antagonist, like cetrorelix or ganirelix, whenever we give an antag, it directly goes and blocks the pituitary receptors. So it prevents LH surge and premature ovulation. So on the other hand, agonist initially causes flare effect and then causes downregulation of the pituitary. Yeah, so whenever we do ovarian stimulation, multiple follicles will be developing, right? So all the follicles will cause rapid rise in the estradiol levels. So estradiol in low levels, it will cause a negative feedback effect on the pituitary. It will inhibit FSH, but at a certain estradiol value, it causes positive feedback on LH. So that's how ovulation happens with LH surge. So there is risk of premature LH surge with rapid rise in estradiol levels. So we have to control that in stimulation with either using agonist or antagonist or progestins, so that we can do a timed oocyte retrieval. The basic concept of downregulation is that on baseline before starting stimulation, the estrogen should be less than 50 and progesterone should be less than 1. And there should be no performances or any dominant follicles. So before starting stimulation, we need to confirm whether it is downregulated or not. Now coming to the antagonist protocol. Yeah, we have now third generation antagonist. So without barely any side effects, we can use antagonists. So almost all cycles now we do are anti cycles only. The mechanism is the antagonists block the GnRH receptor in a competitive fashion and they do not have any flare effects. So they cause immediate suppression of gonadotropins. This is the main advantage with antag protocol. And after the antag is discontinued, even the recovery also within 2 to 4 days, it will be normal. This is the antag protocol. How we do. On day 2, we do a baseline scan and the hormonal profile. If everything is normal, then we start with 150 to 200 units of FSH. Now we are doing the combined FSH plus HMG protocol. So we combine RFSH with 150 to 200 RFSH, even with HMG 75 or 150. And we give for 4 days and we do the scan. On day 5 or day 6, we see the follicle sizes. So if we see 1 or 2 follicles more than 12 to 13 mm, then based on the estrogen values, we can start with the antagonist. and monitored according to ultrasound and based on the hormone values, we monitor the follicle sizes. And whenever at least 3 follicles more than 17 we can trigger with either HCG or agonist trigger. Then we can do the outside retrieval. So this is the ANTAC protocol. So on day 2 or day 3, we see the scan, we see the follicles. If everything is baseline, we start with FSH and H1 gonadotropins. We can do either a fixed antagonist protocol or a flexible protocol. In fixed antagonist protocol, what we do is without seeing the follicle sizes, on day 6, we start with the antagonist and continue giving antagonist till the day of trigger. But in a flexible protocol, what we do is, according to the scan, whenever the dominant follicle reaches 14 then we start with the antagonist and continue antagonist along with the gonadotropins till the day of trigger. This is the fixed and flexible protocols. Now, this is the fixed protocol. On day 6, we start with the antagonist. And this is the flexible antagonist protocol. We monitor the growth of the follicles, we monitor the estradiol values, and based on that, we start with the antac. So the main advantage with antagonist protocol is it is more physiological and the less number of injections. In agonist protocol, we start from the previous cycle itself, and patient has to take injections for a longer period of time. But this ANTAC protocol is less stressful due to shorter treatment cycles. Even the dose of gonadotropins also will be lesser in an ANTAC protocol compared to the agonist protocol. And with the advent of ANTAC protocol, the chances of OHSs are almost negligible. We are running completely OHSs free clinics due to ANTAC protocol. Because in ANTAC protocol, we can give an agonist trigger for the PCOS patients. But whenever we do an agonist protocol, we have to give only HCG trigger, which can give rise to ovarian hyperstimulation. So the main advantage with ANTAC protocol is negligible chances of OHSs, and ANTAC protocol is cost-friendly and flexible. But the disadvantage is that we cannot suppress the raised LH levels early in the phase of stimulation. Like initial first 4 days, we are not giving any pituitary down regulation. So sometimes the LH levels might not be suppressed properly. So only that thing, and we cannot allow programming. Like in agonist protocol, we can give agonist for the number of days we want, and we can actually time the cycle. But in ANTAC, it is not as so. So which to choose among the protocols, which protocol is best means so almost all cycles we are doing are ANTAC only now, but according to the patients, if they are not getting good response with antagonist cycle, based on the patient profile, we can switch over to the agonist protocol as well as the progestogens. So nothing is better than any other protocol, but mostly we are doing our ANTAC cycles, but according to the patient profile, we can do agonist as well as progestogen PPOS cycles also. Next, coming to the agonist protocol. Agonist protocol, the main mechanism of action of agonist is it causes initial flare effect on the pituitary. So it will cause increase in FSH and LH. So that at high doses, continuous exposure causes pituitary downregulation and desensitization. Then we start administering FSH, LH, and then we stimulate. So we can give daily subcutaneous injections, or we can use depot preparations also in agonist protocol. Some intranasal sprays are also available. So the agonist preparations which are available are leuprolide, goserelin, buserelin, and decapeptydyl, that is triptorelin. So the drugs which we are using are leuprolide and decapeptydyl, that is triptorelin. So this is the long protocol. So in long protocol, what we do is in the previous cycle on day 21 itself, we do the scan. we confirm ovulation and if there is any cyst or not. So after confirming ovulation, we start with agonist on day 21 or day 22 of the cycle, and we wait till day 1. We can even add a progesterone for withdrawal bleed, and we continue till day 1 or day 2 of the cycle. On day 1, day 2 of the cycle, we confirm down regulation. We check the E2, estrogen and progesterone values. After confirming down regulation, we start with the gonadotropins, and we reduce the dose of agonist by half from day 2 or day 3 of the cycle, and continue the same dose of agonist till trigger. So this is how we do the long protocol. In the agonist protocol, we do have a short protocol also. In this, agonist is stopped on the day 1 or day 2. Agonist is given from day 21, and day 1 and day 2, we stop the agonist in early cessation agonist protocol. And follicular early cessation agonist protocol, we stop the agonist later in the day, on day 5 or day 6, we stop the agonist. In both protocols, we have to start agonist from day 21 itself, but in early session, we stop on day 1. In the late protocol, we stop the agonist on day 5 and day 6. So this is the short protocol. Yeah. We have another protocol, that is a microdose flare, where we use OC pills for 14 to 21 days. On day 2 or day 3 of cycle, we start the stimulation with a low dose of lupride, 40 micrograms, and we continue till the day of trigger. This is microdose flare. This protocol, especially in poor responders, this protocol will be useful. And then we have the PPOS protocol, that is progesterone primed ovarian stimulation. In this protocol, what we do is on day 2 or day 3 of the cycle, in a routine manner, we start with the gonadotropins. Along with the gonadotropins, we give progesterones, either dydrogesterone or medroxyprogesterone acetate, 10 milligrams BD. We can start on day 2 or day 3 of the cycle along with the gonadotropins. So the main advantage with this is that the cetrorelix antagonist is very costly compared to progesterone. So one thing is the cost factor, and we can start progesterones even on day 2 or day 3 of the cycle, so that we'll be able to control LH surge in a better way. So this is the mechanism of pituitary suppression by progesterones. Progesterones in higher level can decrease in the GnRH pulses, so they can suppress pituitary and they can block the LH surge. So there are so many studies which compare different antagonist, agonist as well as PPOS protocols. So in terms of pregnancy outcomes, embryo euploidy rates, and the blastocyst formation rates, the progesterone primed ovarian stimulation is equally effective to agonist as well as antagonist cycles. But the only thing which with the progesterone primed ovarian stimulation only disadvantage is that we cannot do a fresh transfer, because we are giving progesterones from day 2. The endometrial phase will be advanced. So we cannot do a fresh transfer. That is the only thing. So whenever we are not planning for a fresh transfer, we can safely use a progesterone primed cycle for all patients. So this is the chronic low dose step-up protocol. We can use this protocol in PCOS patients. So in this protocol, what we do is we start with a low dose 37.5 or 75 international units, and based on the size of the follicles, we increase the dose. So on day 4 or day 5, when we do the scan, if all follicles are less than 10 mm, we double the dose by 37.5. So like that, we increase the dose. This can be done in PCOS patients to prevent hyperstimulation. But routinely we are not doing this chronic low dose step up, but we'll monitor in a close manner in PCOS patients to prevent hyper-response. So this is the mean number of oocytes which are needed to get one euploid blastocyst. So when age is less than 35, at least we have to get 5 mature oocytes to get 1 euploid blastocyst. And as age increases, we have to get more number of oocytes. 9 mature oocytes are needed to get at least 1 euploid blastocyst. As we all know, as age increases, the euploidy rate comes down. So at the age of 42, 43, we need at least 16 mature oocytes to get 1 euploid blastocyst, because the euploidy rate will be very less with advancing age. So this will be useful to counsel patients regarding the outcomes. So, what dose to start with? The standard stimulation dose would be 150 to 225. Based on the patient's age of the patient, BMI of the patient, based on that, we decide the doses. So, especially in poor reserve patients with higher BMI, we need more doses, like 400, we can go up to 450. Whereas in PCOS patients, we start with low dose and then accordingly we increase the dose. But giving more than 450, like very higher doses to increase the oocyte numbers, does not actually improve embryo quality or live birth rates. So these are the markers of ovarian response. Main thing is the age, BMI, and already if they have done one stimulation, how was the previous response to stimulation, whether the number of follicles, that is AFC, AMH, and the FSH on day 2. These are the main things which determine the response to stimulation. So, whom do we call as a normal responder? A patient with regular cycles, age less than 37, with AMH between 1.5 to 3.5, and an AFC count on day 2 between 8 to 15. And if they have done a stimulation in the previous cycle, previous normal response to stimulation, those people we call as normal responders. So if the AMH is less than 1.4 or FC is less than 8 and day 2 FSH greater than 12, age greater than 37, so they will be poor responders. And if the AMH is more than 3.5, AFC more than 15 and previous hyper response to stimulation, we can consider them hyper responders. So usually in a normal responder, we aim for 8 to 15 follicles. If we get 1 to 4 follicles, we can call them poor responder. Hyper responder more than 15 follicles. So this is Bologna criteria, especially for poor reserve cases. So what it includes is advanced maternal is more than 40 years, and previously a poor ovarian response to stimulation with a conventional normal stimulation protocol, they might have got a poor response, or an abnormal ovarian reserve test, that is AFC or AMH less than 1.4, they can be included in the poor responder group. But this criteria was previously used, but nowadays we are following Poseidon criteria for poor responders, because this criteria did not include a few genetic factors, and we cannot categorize poor responder cases, all poor responder cases. So this particular Bologna criteria is not being used now. So what we are using now is this Poseidon criteria. So in Poseidon criteria, poor responders are divided into 4 groups. So group 1 patients, these are young patients with normal reserve, but still they get a poor response. So poor response is different from poor ovarian reserve. So these Poseidon criteria are poor responders. So they might have normal age, normal ovarian reserve, but still they can get a poor response. So not only patients who have less AMH and less follicles will get poor response, but sometimes patients who have normal AFC, normal AMH also, they might also respond poor. So this criteria includes all of them. So in group 1, age less than 35, just
సున్నా వాళ్ళు ముందు 90s వచ్చారు కదా మామ, ఆ రోజు నుంచి మెడిసిన్ స్టార్ట్ చేయలేదంట. ఇప్పుడు వచ్చారు మెడిసిన్స్ తీసుకోవడానికి.
ఒక 5 minutes క్లాస్ In group 1 patients, age less than 35, AFC greater than 5, normal AMH greater than 1.2. It is divided into subgroups 1A and 1B, where we get less than 4 number of oocytes in a previous stimulated cycle. So young normal reserve patients who respond poorly are included in group 1. Group includes age greater than 35, AFC greater than 5, and AMH greater than 1.2. So the older patients with normal ovarian reserve are included in group 2. And group 3 includes poor reserve patients, age less than 35, and AFC less than 5, and AMH less than 1.2. They are included in group 3. And group 4 patients, age greater than 35, AFC less than 5, AMH less than 1.2. So these are true poor responders with low ovarian reserve and as well as age factor, the group 4 patients. So how do we manage these poor responder cases? So in group 1 patients, usually the AFC is normal, AMH is normal, and age is also less. So the reasons for low response might be to check for BMI, if any underdosing, and some patients even will have genetic polymorphisms of FSH and LH receptors. So they might need both combined FSH and HMG. So we have to check if there is any genetic polymorphism. And if there is any asynchronous development, we have to give some pre-treatments to correct the asynchrony. So these factors can be looked into in group 1 patients. So in group 2 patients, these are older patients with good ovarian reserve. In this, we can go with the ANTEG protocol with estrogen pre-treatment. So whenever we get an asynchronous cohort, we can start estrogen in the previous cycle so that we get a synchronous cohort on day 2. So we can use that, and we can try increasing RFSH doses, and we can add HMG component also during stimulation for these group 2 patients. We can increase FSH doses, but increasing beyond 300 international units does not seem to benefit according to so many studies. So group 3 and group 4 patients, these are the patients with poor ovarian reserve. So for this set of patients, we can try giving some growth hormone, antioxidants, all those things we can try. And we can go with the little mild stimulation protocols also we can use in group 3, group 4 patients. Giving more dose of gonadotropins will add more cost to this set of patients, because anyway, patients with poor reserve will get little lesser outcomes. They might get less number of oocytes and less number of good quality embryos. So we can go with either mild stimulation or modified natural cycle IVF in these set of patients. So another thing we can do for poor reserve patient is the dual stimulation approach. So in this dual stimulation approach, what we do is in the follicular phase, we do the conventional stimulation from day 2, day 3. We do stimulate, retrieve the eggs, and after the oocyte retrieval, again in the luteal phase, after 2-3 days of giving trigger, we can again start stimulation in the luteal phase as well. So we get all the follicles from the follicular phase and luteal phase. We can do 2 stimulations in the same menstrual cycle for retrieving more number of oocytes. So this is the dual stimulation approach. So we stimulate from day 2, day 3 of cycle. We do the oocyte retrieval. And then again, after the oocyte retrieval, again we can start stimulation, because this recruitment of follicles, follicular wave is a continuous process. So not only on day 2, day 3, these follicles, there is continuous wave of recruitment of follicles. So we can stimulate even in the luteal phase. So, and even so many studies have shown that the embryos which we get in the luteal phase will be of better quality compared to follicular phase. So they got very good quality embryos and good outcomes even with the luteal phase oocytes. According to studies, it says first even studies more terrible because even it's have for long duration. So in poorness and protocol is beneficial. When to add LH activity? So initially we stimulate only with RFSH, but in few cases from the initial days itself we have to add more LH also. Advanced days more than 35 years, poor responder cases, and no response on day 6. For these cases we should add LH activity also. But in our center we do stimulate with combined FSH plus HMG only. Yeah. So how do we monitor a case during stimulation? So ideally, the growth of the follicles should be more than 2 millimeters per day, and we monitor with estradiol values also. So estradiol values also we measure on day 1 as well as day 5. So more than 50% per day increase in the estradiol values. And there will be an increase in the endometrial thickness as well. Yeah, so the first scan when we do on day 2 or day 3 of cycle. So this is the baseline scan. In this scan, no follicle should be greater than 9 mm, and any cyst if there, we have to see whether it is a functional cyst or not, and the hormone should be baseline. Yeah. So the purpose of baseline scan is to rule out any cyst and to see the AFC. So on day 2 and day 3, before starting the dose, we see what dose to start based on the AFC, based on the AMH, based on the age of the patient, based on the previous response. If any stimulation they have already done, previous response to stimulation also we should consider. And based on the value C2, P4 and FSH, LH baseline hormonal values we'll do. And then accordingly, based on the factors, we'll decide upon the dosing and the protocol also. Yeah. So according to these parameters, we'll decide upon the protocol. So for all type of responders, we can consider doing an anti protocol. So in few cases where there is a follicular asynchrony, then we can consider doing the long agonist protocol. The starting dose in low responders, it should be 300 international units. And in the normal responders, we start with 225. And in high responders, we can start with 150 also, 150 international units. Yeah, on day 5 of stimulation, we see the scan. We see the size of the follicles. So if the follicle sizes are they haven't grown or less than 10 mm, we increase the dose, and we have to monitor the estradiol values also. If any follicle greater than 14 mm, we start with the antagonist to prevent LH surge. Yeah, on day 6 to day 8, again we monitor the response, see the size of the follicles, whether they have increased or not. And as well as the endometrium, we monitor the follicle diameters as well as the endometrium. And if there is no satisfactory response, we can consider increasing the dose to a maximum of 450. So again, on day 9 of stimulation, we see whether how many mature follicles are there. If 2 to 3 follicles more than 17 mm of size, we can see, and adequate rise in the estrogen values of at least 250 picograms per ml per each follicle we should get. So based on that, we'll decide upon the trigger or whether to continue stimulation. Yeah, so when to give trigger, 3 or more follicles greater than 17 to 18 mm and endometrial thickness 7 mm. And each mature follicle produces around 200 to 400 picograms per ml of estradiol. So based on the estradiol values, we'll decide upon the trigger. So what is the choice of trigger that we give? We have HCG or HCG dosage is 5,000 or 10,000 international unit ml. HCG, the most common trigger which we use is HCG, or we can give recombinant HCG as well. 250 micrograms of recombinant HCG is equal to 6,000 to 7,000 international units of HCG. And we can give either an agonist trigger with either leuprolide or triptorelin, that is a decapeptidase. So urinary HCG remains the best choice based on the cost as well. HCG is a better trigger. In high responder and PCOS patients, we should avoid giving HCG because in order to prevent the risk of OHSS, we can consider giving agonist trigger in PCOS cases. But whenever we give an agonist trigger, it causes downregulation of the pituitary. So whenever we give agonist trigger, we should not do fresh transfer because so many studies have found that when we give an agonist trigger, the lower live birth rates and higher miscarriage rates in women who received agonist trigger. So with HCG trigger, we can plan for fresh transfer. Whenever we give agonist trigger, mostly we consider doing freeze-all cycles. Yeah, but in high response cases, when we use HCG as a trigger, it may cause OHSS. So we consider giving agonist. Yeah, only when agonist is given as a trigger, it eliminates the risk of OHSS. But disadvantage is that especially in patients with very low LH levels, we might get some empty follicles. So based on case, we have to decide if any previous empty follicle syndrome or some any other factor poor response, we can consider giving dual trigger both with agonist as well as HCG. Agonist trigger, we can give 0.2 to 0.4 milligrams of decapeptidase or triptorelin instead of HCG. Yeah, we can consider dual trigger in few cases, that is HCG as well as agonist together we give, so that it will lead to better maturation rates. So in hyperresponders, we can do segmentation IVF, that is we should do IVF protocol with agonist trigger plus freeze-all, which will almost eliminate the risk of OHSS. We can run in OHSS free clinic with antagonist protocol with only agonist trigger, and we'll freeze all the embryos and transfer in the next cycle. So with this approach, we can prevent OHSS in hyperresponders. Yeah, a few points in anti cycle. Prevent asynchrony on day 2 of cycle, we can consider pre-treat with estrogen or progesterone day 1 previous. The antagonist should be initiated at 4 mm rather than a fixed protocol. Antagonist we can give whenever a dominant is 14 mm size, it is ideal to start antagonist. And increasing the FSH dose, there is no benefit of increasing FSH too much or adding LH from the day of anti. So we can consider giving both FSH and HMG, that is LH also from day 1 of stimulation. And the time interval between each anti injection should not exceed 30 hours. And the time between the last dose of antagonist, especially on the day of trigger, the time interval between the last dose of antagonist and giving the HCG trigger should not exceed 30 hours. So is there any way we can avoid asynchrony of follicles on day 2? As I already told, we can do luteal phase estradiol priming. That is from day 21 of the previous cycle. We can start low dose estradiol 2 mg BD from day 20 till day 1 of the cycle. We can consider giving so that we can see a synchronous cohort of day 1 or day 2 of the cycle.
Take screenshots, we can read and discuss.
So this is one more new concept, random start ovarian stimulation. So in random start ovarian stimulation, what we do is we start stimulation on day 2 or day 3 of cycle. But in random start, we can start ovarian stimulation in any day of the cycle. So this is a very good concept which came lately. Nowadays, we are doing so many random start stimulations also. Especially in the follicular phase, we'll get a doubt whether if there is any dominant follicle on the scan, we'll hesitate to do stimulation. But the thing is, these wave of follicular recruitment is continuous. So there are multiple waves of recruitment in a single menstrual cycle. So we can, whenever we stimulate in any day of the cycle, we'll be able to get embryos and oocytes equally compared to anteg cycles. So even patient comes on day 12 or day 13 of stimulation, day 13 of cycle, we can see the scan. If there is any dominant follicle, we can give trigger and start stimulation. So especially in the follicular phase, if the lead follicle is less than 12 we can directly start away the stimulation. And if there is any dominant follicle, we can trigger and start the stimulation as well. And in the luteal phase, we can start off stimulation after confirming ovulation. So if the patient presents with a dominant follicle, we can give trigger here. If patient presents in the luteal phase, directly it can be started. So especially this protocol is useful whenever patient wants to leave somewhere to a foreign country, or cancer patients who are planning for a chemotherapy. In these kind of patients, when there is no time, we can directly start away stimulations and get good results with this in these cases. So, and oocyte cryopreservation also. Nowadays, as so many people are postponing marriages and pregnancies, we can give the option of oocyte freezing with these protocols, and the success rates are also good. So they can keep it, especially cancer patients, poor responders, so they can freeze their eggs. So that is about all the stimulation protocols. Any doubts regarding the protocols? So among all these protocols, not to confuse you, you can mostly use antag or agonist protocols. You can learn those two protocols well, and later on, according to patients, you can try other different protocols. If you don't have any doubts, we can wind off the class.